Right, good morning, everybody. Today, I'm sharing some information I got from attending the knee HMDP that occurred in SGH 3 weeks ago. A few of us went for the HMDP sharing, so I'm just sharing part of it. Hope you enjoy. So this is the content that he covered for the whole day, and I'm just going to cover four topics here. The subacute rehabilitation, knee flexion deficit and management, arthrofibrosis diagnosis, definition and management, and the role of manipulation under anesthesia, MUA, and its aftercare. Okay, let's start with subacute rehabilitation. So he shared that reconstruction surgery is not just about pain relief anymore. Function matters. So it used to be that a lot of people come to TKRs because they couldn't bear with the pain. It was affecting their activities of daily living. But now more and more people are coming for TKR because there are things that they want to do that they can't do. For example, doing some form of sports, or being able to climb stairs, or walking and standing the whole day for work. These patients do not necessarily have pain on a regular daily basis, which affects their ability to function at the most basic level. That's why we have to find out their goals, and we have to get them back to the function that they hope to achieve. So for rehabilitation goals, the most important would be to achieve 0 degrees of knee extension, because anything less than that, it will cause early wear out of the prosthesis. And next will be knee flexion. So it used to be that we are happy with 90 degrees of knee flexion, but we know that that's not sufficient anymore. Right? So yes, it used to be that 90 degrees we were happy with a result with 90 degrees post-op. But nowadays for function, we know that to climb stairs, to cycle, to kneel or to squat, which the new prosthesis allow us to do, 90 degrees of knee flexion is not sufficient anymore, and we need to educate the patient and modify their expectations such that they're not pleased with just 90 degrees. They want to achieve more than that. The last, strength and control are really important to utilize the knee flexion range that they have. Some of them will need to climb stairs, will need to do sports, and sufficient strength and control is really important to prevent early wear out of the prosthesis as well. For patient and management stratification, now in any large population, and considering that we do more than 1,005 knee operations a year in Singapore, that's pretty large. There will be a large range of variable results and responses. This is just because in our population there are diverse risk profiles. So one good example would be that if 30% of our population is born with increased inflammatory markers, then we would expect a significant number of them to do poorly with swelling and decreased knee range and decreased quads activity. So the question comes when how do we manage these patients? Do we push the squeaky wheels who don't do so well, or do we focus on the performing group where with a little bit of effort they could be pushed to do a lot, or they could achieve a higher amount of performance? So how do we stratify these patients for intervention? So move on to risk of poor outcomes. How do we know which patients at risk of doing poorly after a TKR? So one of the first ones would be the history of previous knee operations. So if patients had surgery many years ago, and that back then surgical techniques were not so good, we would expect a little bit more scarring and fibrosis than let's say ACL op today. And if these patients had history of infection where there could be possible laying of more scarring and fibrosis, recurrent knee surgeries, 4 or 5 surgeries until they finally got a TKR, or whether they had residual contractures, these are signs that fibrotic tissue has already been laid down, and we would expect that it's more difficult. First, they are a bit more at risk of fibrosis already, and second, there's a lot more scar tissues to deal with this time round if this is the fifth operation. um, Next will be joint contractures. So for an example would be if the patient already has a knee valgus contracture or deformity, and we straighten the knee alignment after the TKR, then they are at higher risk of peroneal nerve entrapment or stretch, and this could produce a significant pain and dysfunction. For patients with mild neurological conditions, they already have problems with strength and motor control, so we would expect that their outcomes would be worse than those with an intact neuromuscular system. And he has noticed that patients with pre-existing stroke, they do very poorly. For postmenopausal women, they do have a bit more high intramuscular fat. So in terms of strength gains, they may not do as well, or they may have higher amount of muscle inhibition post-op. For those with high BMI, we already know there's an early wear and tear of the prosthesis. They would have trouble, supporting their weight post-op. So in terms of mobility, they may not regain the functional mobility as fast as a person with normal BMI. As with obesity, we also know that there are increased inflammatory markers in anyone who's obese, and that would also affect the post-op outcomes such as swelling and scar healing. For aggressive runners and cyclists, this is new to me. He did share that these people who are very, very active, they do have very tight ITB or ITB hypertrophy, and they could potentially end up with RSD and CRPS where they have uncontrolled pain, and that will affect their post-op outcomes. The use of atypical pain medication may not apply in Singapore because some of these patients may have abused or be dependent on narcotics before op, and in the US they're very strict with narcotics use in the hospital. So aside from a less basal narcotic medication use, they have a post-operative pain, and that can result in very poor pain control and poorer outcomes. In terms of age, is it better if you're young? Not necessarily. The too young, if you're too young, it's equally hard as if you're too old. One reason could be that these young people do have extensive knee damage and knee pain by the time they require a surgery when they're this young. So this could result in poorer outcomes. There's no hard and fast rule for gender's impact on the outcomes, because he did say that the young obese female with atypical analgesia use before surgery usually perform the worst, but on the other hand, female patients are usually more compliant to exercise as well, so gender works both ways. Okay, let's move on to the next slide.